Good evening and welcome to Medicine in Our Backyard. This is a series presented by the Newport Beach Public Library Foundation in partnership with UCI Health. My name is Adrienne Windsor. I am a member of the Newport Beach Library Foundation and I am so happy to welcome you here. We would like to thank our generous sponsors, Mike and Polly Smith. They have been with us since the beginning of this program. Just to be sure that we do everything according to plan, the Q&A session will be at the end of the lectures by our two speakers tonight. So we request that you hold all questions until then. Please use the Q&A box to ask any questions instead of the chat. Now, let me tell you a little bit about the foundation. We are a membership organization. We welcome new members, so if you aren't a member, we hope you will join us. It's been wonderful that we plan to do at least January and February by Zoom for Medicine in Our Backyard, because with the Omicron variant, we are having to postpone some of our presentations. The witty speakers for January and February will be postponed until the last 2 Fridays in April. As a membership foundation, we provide many things for the library that the city does not provide. Among them, during this pandemic, the e-library has been very, very important to those who couldn't come in. So I hope you take advantage of that. I hope you take advantage of our media center. I hope you appreciate all of the special things that we have been able to provide for the library over the years. And now, if I could introduce our two speakers for this evening, Doctors Vivek Patel and Austin Fox. Dr. Patel is a board certified UCI Health ophthalmologist who specializes in neuro-ophthalmology and adult strabismus. As chief of neuro-ophthalmology services, he brings considerable expertise to the clinical and surgical treatment of visual pathways disorders. He earned his medical degrees at the University of Saskatchewan College of Medicine in Saskatoon, followed by an ophthalmology residency at McGill University Health Center in Montreal, Quebec. He completed a fellowship in neuro-ophthalmology at Keck School of Medicine at USC in Los Angeles. He is a diplomat of the American Board of Ophthalmology and a fellow of the Royal College of Physicians and Surgeons of Canada. Dr. Austin Fox is a UCI Health ophthalmologist who specializes in the diagnosis and treatment of cataracts and glaucoma. He earned his medical degree at the University of South Alabama College of Medicine in Mobile, Alabama. He completed an internal medicine internship and ophthalmology residency at the University of Iowa Hospitals and Clinics in Iowa City, where he also received fellowship training in glaucoma. His research interests include autoimmune retinopathies, retinal disease, and age-related macular degeneration. So let me welcome first Dr. Austin Fox, who will begin our presentation tonight. Please join me in welcoming him.
Thank you. So thank you for the introduction, and it's a pleasure to be here and presenting to you and Dr. Patel. This is a timely topic because, as you may know, January is the National Glaucoma Awareness Month. And we'll talk about glaucoma, how it affects the eye, and how other neurological conditions might also. I'm just going to share my screen right here. All right, very good. So let me just see if I can advance. All right, so just as background, we know that the eye focuses light. It focuses light onto a tissue in the back of the eye called the retina. And so one of the cells of the retina is the optic nerve cell, which connects to the brain. So the light signal is processed by the retina and optic nerve cells and sent to the brain, where we experience vision. So the optic nerve is a bundle of nerve cells. It's about 1 million nerve fibers responsible for transmitting nerve signals to the brain. And this picture on the right is the image that an ophthalmologist sees when we look into the back of the eye. This is the front surface of the optic nerve, which is what we look at to evaluate for glaucoma. Glaucoma, well, it's a family of diseases that results in acquired progressive thinning of the optic nerve, which you can see at the rim here. And so with these arrows, and you think of this, you can think of it as like a donut. If there's a thick rim of dough, then the nerve is healthy, as seen here on the left, right here. But if there's a thin rim or a thin amount of nerve tissue, as seen on the right, then this is glaucoma. And this may be referred to as cupping. So why is glaucoma important? Well, because number one, it results in permanent vision loss, and the vision loss is initially peripheral vision loss and later central vision loss. And it's generally asymptomatic until vision loss extends more centrally. Number two, glaucoma is important because it's a treatable disease, which is relevant because glaucoma is the second leading cause of blindness in the United States. So screening is essential. Let's discuss what a typical exam and glaucoma screening might look like. Basic elements of a glaucoma screening include vision, intraocular pressure, as well as an examination of the front and the back of the eye with close attention to the optic nerve. So in this case example, a patient sees an ophthalmologist for a routine exam. The visual acuity is perfect at 20/20 in both eyes. The intraocular pressure is a little high, normal being anything below 21. And it's 27 here in the right eye and 24 in the left eye. And this is the same view that an ophthalmologist sees at the back of the eye. You can see that in this case, the optic nerves look a little bit different. And if we were to outline the darker rim of the nerve, which is the actual nerve tissue, then the rim would be thinner for the nerve on the left side of the screen, right here. Or this is actually the right eye, which you can see here with the highlighted red rim overlay. So the optic nerve rim is thinner on the right eye, and the appearance of this nerve would prompt us to perform a visual field. So there are lights shown in this machine to test our peripheral and central vision, and we get a readout like this. On the left, this visual field for the left eye, as if you are looking out with your left eye here, is normal. And this is a normal, dark, physiologic blind spot. That's where the optic nerve enters the eye. So the dark spots mean that you do not see lights in that area. So for the right eye, you can see that we have a visual field defect in the supranasal area. After the visual field, we will obtain a sophisticated picture, essentially, to analyze the optic nerve, which you may hear this called an OCT for short. This allows us to measure the thickness of the optic nerve, which is shown by all these numbers, and it lets us look at how thick the optic nerve is. So let's look at the nerve on the right, which is on the left side of your screen, and you can see that there is thinning superiorly and inferiorly. And let's compare this to the optic nerve on the left eye on the right side of your screen, and you can see that there's a green here. And so what this means is that the thickness is normal compared to a healthy nerve for this age group. So let's just put all this together. So how are the thinning of the nerve and the visual field defects related? Well, this is a healthy visual field. And at the back of the eye, you can see the optic nerve and optic nerve cells spread out across the back of the eye, across the retina. But they're so small, you can't see them. So right here, I overlaid these blue cartoon cells to depict the optic nerve cells as they combine to form the optic nerve. There are about 1 million of these cells. But for simplicity, I'll show 5 superior cells, 5 inferior cells, as well as a healthy optic nerve with a healthy rim. As the optic nerve becomes damaged in glaucoma, we lose these optic nerve cells. And you can see now there's 4 inferiorly. And just to note, and to keep things clear, the damage inferiorly on the optic nerve results in a superior visual field defect. So as we lose more cells, the visual field defect gets larger. And if things progress, we may lose the superior optic nerve cells. Now we have 4 cells superiorly and 2 inferiorly. And so here, unfortunately, in some patients, there can be progression and loss of optic nerve cells that results in, the visual field becoming severely limited, as you can see up here. And to put this together, so you can see this progression over the years, glaucoma may result in progressive loss of the optic nerve cells here, gradual cupping, where you can see this white cup here gets larger and larger. And then you can see that there's gradual loss of the visual field. Fortunately, we may be able to slow down or halt this progression with treatment. So how do we treat glaucoma? Well, intraocular pressure, the pressure inside of the eye, is the only risk factor which we can modify to slow the progression of glaucoma. And I put this over here because it's sort of a plumbing issue. Fluid enters the eye and fluid exits the eye through a drain. And the pressure rises if the drain is clogged or does not work appropriately. And the higher the pressure, then the more likely that there is to be damage to the optic nerve. So all treatments work to lower the eye pressure. So back to our case, we started eye drops to lower the eye pressure, and we were able to do that effectively with just the eye drops alone. However, we still had progression of the visual field defect despite controlling the intraocular pressure. So this has me asking, what is going on? Is this really glaucoma? The visual field looks like glaucoma, but there is steady progression despite the lower pressure. In these cases where there's this sort of progression or the case is not completely classic, it's, as it is with this unilateral case, neuro-ophthalmologists like Dr. Patel and I work together to answer the question, is this glaucoma or should we be thinking about something else? All right, so we're going to pass off to Dr. Patel right here, and he's going to take the control from here.
Can't hear.
Thanks so much. Can you hear me okay, Austin?
We can hear you.
Okay, great. All right. Well, thanks so much. That was a really nice introduction about glaucoma and essentially how we all work together. We all like to have our silos and our subspecialty training, and we obviously become deep in an area, but it all does overlap. And glaucoma specialists work with neuro-ophthalmologists, and we work with retina specialists and so forth. And that's what's really nice about having a good team. And as Dr. Fox mentioned, sometimes it can look classically like glaucoma and it's treated like glaucoma. And other times, glaucoma being just one type of an optic neuropathy, although one of the most common and prevalent forms of optic neuropathy, certainly there are other things that can be going on that can give you a very similar picture in the eye itself and a similar involvement for the patient. We need to remember that the optic nerve, as Dr. Fox mentioned, it's here you can see, this is the part that we can see through the eye on an MRI, but there's a whole optic nerve that goes into the brain. And you can see a part of the optic nerve here that goes into the brain. And then there's visual pathways, roughly 40 to 45% of the brain is actually devoted to some form of visual function. And now we have such exquisite neuroimaging techniques that we can actually see individual fiber bundles as they extend into the brain, which actually form the visual pathway. So the optic nerve, the million or so cells that Dr. Fox mentioned that coalesce at the level of the optic nerve, they enter and they go down this nerve, they enter the brain, they go down this nerve all the way in, and they'll take it over here. This is where they cross, and they can go in what's called an optic tract, and then radiations that further go into the brain. So essentially, what we perceive at the very front part of the eye at the level of the optic nerve goes all the way back to the back of your brain. So you can imagine that sometimes a visual field problem or something that looks like glaucoma could actually be rooted in the brain itself. And that's where we work together to determine if something is a little bit atypical. Okay, so optic neuropathy and glaucoma overlap. You can see here, if the larger of the circles is the optic neuropathy, meaning anything that can affect your optic nerve, and glaucoma is one large and important component, there may be a number of other things that could be at cause or at play here. So what we do as ophthalmologists, we look at cupping and pallor of the optic nerve. Dr. Fox showed nicely what cupping means, meaning that central core becomes larger because the rim of nerve is becoming thinner. So by just extension, that cup becomes larger. But that the residual rim in glaucoma generally stays nice and pink and robust looking. Whereas with people who have other forms of optic neuropathy, like compression or stroke, or even sometimes inflammation and other entities, that rim may become more pale, may not look nice and robust and pinky orange as it does in glaucoma. The visual field loss pattern, we'll talk about that. Dr. Fox nicely showed that sort of arc-like pattern that takes place in glaucoma. If there are other patterns, we may be thinking about something else. Although glaucoma can have many different types of patterns, there are some classic kind of things that we look for that say, hey, this looks less like glaucoma and maybe like something more neurological. What's an RAPD? An RAPD is a relative afferent pupillary defect. That means that when the doctor, the glaucoma specialist, neuro-ophthalmologist, whoever, they will maybe sometimes flash a light between your left and your right eye and go back and forth. What they're doing is comparing how well each eye constricts, how well the pupil constricts going back and forth. If one pupil does not constrict as well as the other when a light is shone directly in it, it means that it may not be conducting light as well as the other eye. And that's a relative difference. And although glaucoma can be asymmetric, if it's strictly unilateral, we become sometimes concerned something else could be going on. It could still be glaucoma, but oftentimes when it is very asymmetric, we become concerned that there may be something else. Loss of visual acuity. Dr. Fox also mentioned that typically until later in the disease, glaucoma patients with glaucoma tend to be 20/20, 20/25. If there's a cataract, that might be affecting, but the central vision is not usually affected until later in the disease. Whereas other forms of optic neuropathy, it may be something you see much sooner, like optic neuritis or ischemic optic neuropathy, which is lack of circulation to the optic nerve. Even compression from a tumor tends to involve central vision more than glaucoma does. Color vision. Color vision is subserved by the same fibers as the central vision. Central vision is how well you do on the eye chart, and color vision is another sort of functional test that speaks to the same fibers. So usually when we have decreased central acuity, like 20/30, 20/60, 20/100, the color vision also goes down in many forms of other optic nerve disease. Color vision tends to be relatively spared in glaucoma until later in the disease. In so-called normal IOP, we know that there's normal tension glaucoma or patients who have relatively normal IOP but could still have glaucoma. But if the eye pressure is well controlled and the glaucoma specialist feels like, hey, with a pressure that's this low, why are we still seeing progression of the visual field? It could mean that there's something else going on beside glaucoma itself. Okay, so let's go forward with this a little bit more. And I just put some of those things that I talked about. There's so many other things we think about in terms of optic neuropathies other than glaucoma: inflammations, infections, ischemia. You might have heard of giant cell arteritis or temporal arteritis. That's a form of ischemia, which is lack of circulation to the optic nerve. Infiltration, so things like leukemia or other neurological disease, inflammatory disease, can actually infiltrate the nerve, which means those cells go inside the nerve itself. Tumors, benign tumors or malignant tumors, can actually compress the optic nerve. I'll show you an example a little bit later. Trauma, self-explanatory. Multiple sclerosis, it tends to involve people in their 20s, 30s, 40s, 50s, although it can be all the way up to the 60s and 70s as well. So there is some overlap even in the demographic with glaucoma. Toxic, some medications like tuberculosis medications, Plaquenil, amiodarone, which is a heart rhythm medication, are all classic, uncommon, but classic medications that can affect the optic nerve. Even some chemotherapies can affect the way the optic nerve functions. And then there's nutritional deficiencies, in particular B12 deficiency is very, very important for us to consider. Folate deficiency, very important for us to consider. And those deficiencies themselves can cause an optic neuropathy. And there's a whole slew of genetic factors as well. So here when we look at this, this is just sort of an overlay to say that different forms of optic nerve disease can give us different visual field defects. This is somebody that had a nutritional deficiency, had alcoholism, as well as a vitamin B12 deficiency, and there's a central vision loss there. This is a patient with retinitis pigmentosa, an inherited retinal condition where they get this scarring in their peripheral retina, and you can see they have sparing of their central vision and loss of the peripheral vision here on the visual field. This is a patient with a pituitary adenoma, which is a tumor of their pituitary gland that I'm circling here, pushing the optic nerves. The optic nerve gets pushed up and it's causing compression of those fibers, and it gives you a visual field loss, like a tunnel vision. They've lost the outside part of the vision in each eye. We call that a temporal visual field loss. And you can see here, unlike what Dr. Fox showed, there's respect for the vertical meridian here, meaning the visual field loss sort of goes across the vertical. The vertical is a key separation here, whereas before it was more along the horizontal. This is what's called optic nerve drusen. Drusen are basically little crystals or rocks that can form inside the optic nerve, and the visual field loss can be exactly like glaucoma. This is an ischemic optic neuropathy where circulation has been lost to the nerve and gives you what we call an altitudinal. You're missing half of the vision above or below. And this is a tumor. This is an optic nerve meningioma. Meningioma is a benign tumor of the meninges in the brain, and it can wrap around the optic nerve, and it gives you a central field loss. So our visual field is a map. It's a map of where along the visual system the problem is occurring. It may be happening at the optic nerve, or it could be happening all the way down into the brain, and that's where we overlap. So history is the key, and Dr. Fox put this slide together in the timing of vision loss. Some things like strokes occur instantaneously. They are an absolute, I was normal 1 second and the next minute there was a problem. Glaucoma tends to be much, much more gradual than that in the vast majority of cases. And there are risk factors. We ask about age. Generally speaking, although it can affect people at any age, as you get older, with each decade, the incidence increases. Family history is a strong predictor. Race, we see this more in African-American individuals, see this more in Indian-American individuals. Tends to be involves any race, but it certainly does have a predilection for certain races over others. Intraocular pressure, probably the primary risk factor. The higher the pressure, the more likely we are to have glaucomatous damage. And even steroid use, whether that's topical steroid drops, inhalational, or even oral medications, long-term prednisone use can also increase your intraocular pressure and then lead to the possibility of glaucoma. And when we look at other things too, is there pain in the eye? Is the eye bulging forward? That's called proptosis. That means there could be a tumor behind the eye, among many other possibilities, but it's possible, as well as headache. Headache is something that we generally don't see in glaucoma unless the pressure rises very quickly. So the visual field patterns, as I kind of mentioned, in glaucoma, we see a gradual drop in sensitivity. It's a typically gradual thing. This is happening over at least months, more likely years, sometimes so slowly that the patient may not be aware of what's been going on until it gets to a point where it affects their function. And it typically respects the horizontal midline. So if we look at this as the midline, the horizontal midline, there are visual field loss that tends to kind of fall below. It can be above or below, but it tends not to cross the midline until you start to affect above and below. Now, an optic neuropathy, which again is a huge category, but other forms of optic neuropathy, there may be a more sudden or a steep loss depending on the situations, meaning more of an abrupt change. And it tends to respect the vertical, like I showed you here. So that's what we mean by respecting the vertical. The visual field loss falls on either side of the vertical meridian. Okay, so let's look at a case. This is a real case that I had seen some time ago. And the question is, does this patient have glaucoma or something else? And Dr. Fox pointed out nicely this sort of superior and inferior thinning of the right optic nerve. You see this here, and that left one is normal, and the right one shows an upper and a lower thinning. And that is thought to be classically a glaucomatous pattern. But this case proves that it's not always something that we see only in glaucoma. So this pattern is not specific for glaucoma, but it is something that we do see. So we have to be very careful to not oversimplify the findings on the OCT. there are other things that we look at beyond just the OCT. In this patient, the right eye central vision was 20/100. The left eye was 20/25. We just said that, although we can get decrease in central vision and glaucoma, it tends to be a much later finding, and usually the central vision and the visual acuity is preserved in glaucoma. The color plates, which means when you look at the book that ophthalmologists will show you with the various numbers or shapes to look at your color vision, the left eye, 8 out of 8. And in the left and in the right eye, 2 out of 8. And again, in glaucoma, generally speaking, even with lots of visual field loss, most of the time you'll get all of the color plates. RAPD, there was a relative afferent pupillary defect, which meant that when the doctor shone the light in the right eye, it reacted much more slowly than it did in the left eye, suggesting a relative difference with the right eye pupil does not constrict as well, which makes us think about very asymmetric disease. With decreased central acuity and decreased color, we become suspicious. So when we become suspicious, we do an MRI because one of the things we want to look for is compression. In addition to asking about other risk factors, asking about their metabolic health, do they eat well? What are the uncertain medications? Do they have ischemic risk factors like for blood pressure increase and so forth? But to rule out a tumor is very important. And here, I'll put a circle around it. We can see that on that right side, when you look at an MRI, the left side of the screen is always the right side of the body for the patient because we're looking from below. And you can see here, there's a tumor that's surrounding this right optic nerve. And on the coronal section, which means looking straight ahead at the patient, you can see this enhancing structure over here, and that is surrounding the optic nerves. This is a meningioma. So this patient that had this OCT pattern that looked very much like glaucoma, taken together with the decrease in central vision and taken together with the decrease in color vision, made us suspicious for a tumor. And indeed, there was a tumor. Wasn't glaucoma at all. I'll give you another example about how we look at these things. So you have an optic nerve here on the right side. Here's that nice rim, the cup in the middle, as Dr. Fox was pointing out. Here's the left eye. You might sort of agree with me that this looks a bit more pale. You see the cup is here, but the rim looks more pale than it does on this side. This rim is a little bit more orangey pink, and on this side, a little bit more pale. Okay, that's the left eye. Okay, and this is the visual field of the left eye. You can see there's quite a bit more visual field loss in the eye that looks more pale. And in the right eye, where it looks relatively good, not so much paleness, there is a little bit of a defect up above over here. If you just looked at this eye, one might think glaucoma, like I was showing you before. It kind of extends off of the optic nerve, but that vertical respect should make you suspicious. And it turns out there was a tumor. Okay, this is a pituitary adenoma, which is pushing on the optic nerves where they meet in the middle, and that term is called the chiasm. The chi is in Greek is an X, so when they come together, that X point, that's called the chiasm, and that's why you have visual field loss in both eyes. Asymmetric, of course, because the tumor leans more to one side than the other, but again, this is what we have to be very suspicious of. So just cupping itself is not always glaucoma. If we see cupping with pallor, we think about a tumor. Okay, and again, you see that pattern above and below, but if we overread this and oversimplify it, we can miss this, and sometimes it's not glaucoma, it's something else. Okay, and we call it a junctional scotoma because the problem occurs at the junction of the optic nerve and the chiasm. Those nerves come in and they cross at the chiasm, so a mass at that area can give us a problem. So that's what we're looking for. We obviously can't see through the back of the eye into that part of the brain. That's where the MRI comes in. Okay, so kind of to summarize this here, to put the points together Dr. Fox and I have both been talking about, is when we think about a glaucoma versus another form of an optic nerve disease, our red flags, what makes us suspicious, among other things, vertical respect. So here, I showed you again, just to reiterate, this vertical respect. If the visual field comes out kind of linearly along this vertical, we may be wanting to get an MRI scan to see if what's going on behind the eye. This here is more typical of glaucoma. Decreased color vision or visual acuity. That again, they're subserved by the same cells. The visual acuity, what allows you to see the chart, is also the very same fibers that allow you to see color. And so we might show you the plates, the little book But we might also just put up a red cap in front of you and say, okay, with one eye, do you see it nice and vivid and crisp, a nice, a bright hue to the red? And the other eye might look more brownish or desaturated. Now, that could be because of cataract. It could be because of macular degeneration. It's not a specific finding. There's hardly any one smoking gun for us. We have to kind of take everything into a global context, but it can be helpful in the right scenario. And again, as I mentioned before, the optic nerve, more pallor than cupping. This is a glaucomatous nerve. You can see that there is a cup. The cup is larger. It's kind of more vertically oriented, as Dr. Fox showed, but the remainder of the rim is nice and orange and robust. And look at this eye here. You can see here, there is a larger cup, but the remaining rim looks a bit more pale. And we pay attention to these subtleties because it makes us think about something else potentially and not just glaucoma. And again, as I mentioned before, careful not to oversimplify the super and inferior thinning on the OCT as we see here, because that can be something other than glaucoma. So we have a collaborative, of course, we work together to ensure that we have the right diagnosis, and patients can have more than one diagnosis. We all see patients that have a history of years of glaucoma and then unfortunately develop a secondary problem like giant cell arteritis or some ischemic optic neuropathy or a stroke, which then superimposes visual field loss on what they had before. And it can be difficult sometimes to strip that away and for us to kind of understand what part of the visual field loss is from glaucoma versus something else. And that underscores another reason why we have to work together. So, Alston, anything to add at that point? I think that's what we wanted to kind of get across for our initial sort of discussion and then bring it up for questions.
Yeah, fantastic. That's a great, kind of depiction of like how we interact and how we intersect with our specialties. So it's really a collaborative approach.
Well, thank you very much. That's very important. Now, I think probably the audience that you have tonight is of that age that is more susceptible to glaucoma than the younger people. The test that you do when you go in to have your eyes examined and it feels like you just get a little bump, that is testing for pressure?
Correct. So that's testing for pressure, and you can do that in multiple ways. You may see that little pin that we use to, kind of bump on your eye, and some it tends to be optometrists. They use that puff of air, and then with that blue light that we showed, I showed it earlier in the presentation. That also bumps your eye, but that's applanation tonometry, and that's kind of a fancy term for saying, that's a pressure checker.
Okay. It sounds as if there are certain things we can do to protect the health of our eyes. You were talking about nutrition, sort of lifestyle. Are there certain foods that we should be eating that are high in B12 and folic acid?
Sure, exactly. I mean, so some folks are vegetarian, which of course has many health benefits, but then B12 and stuff can be missing for some individuals. So green leafy vegetables are very, very important, in particular for people who are entirely vegetarian. Even just supplementation with one a day is very helpful. I mean, I think that sometimes it takes the mystery out of what we're eating, how much we're getting, but not to overdose on vitamins, but we just really need them in normal levels. There's no evidence suggesting that higher than normal levels of folate or B12 or so forth will be helpful to us, but we just need to make sure that we have adequate levels there. So I think eating a healthy diet in that context, green leafy vegetables. If you don't eat meat, then ensure you have normal proteins and stuff. I think that's pretty much all you need from this standpoint. It's kind of uncommon to have these deficiencies, but it generally tends to be paired with individuals who might have some sort of a malabsorption issue, or even alcoholism. That's relatively common, but we don't talk about it too much. And what can happen over time is that it can affect the way that your intestinal enzymes can absorb the normal nutrients. So I think it's very, very important. Gastritis, long-term gastritis can damage these cells in the stomach called parietal cells, which are very, very important and work with the other cells in the stomach to absorb B12. So that's also very, very important.
Right, we have a question here about the prognosis for pigmentary glaucoma.
That's for Dr. Fox.
Yeah, so good question. Pigmentary glaucoma, you have to kind of differentiate pigmentary glaucoma from pigmentary dispersion syndrome. So, this happens when the pigment in your eye can be, dispersed or liberated. And essentially what happens is that pigment clogs up the drain. I will say, if you clog up that drain enough, then, the pressure can rise. But I will say that blindness from pigmentary glaucoma is rare. So, there's been a couple of community studies with pigmentary dispersion syndrome, but about 10% of patients with pigmentary dispersion syndrome progress to pigmentary glaucoma at 5 years. 15% patients with pigmentary dispersion syndrome progress at 10 years. And then, once you get to a certain point, the pigment in your eye disperses so much that there's not much more pigment to disperse. So, your pressure starts to normalize. And we actually call that a burnout of the pigmentary dispersion syndrome, or burnout of the pigmentary glaucoma.
Okay, thank you. I have a request here that you talk about the advances in peripheral eye tests. This questioner, Larry Fort Muller, I have heard that there are tests coming up that do not require pushing a trigger during the test. Having taken dozens of these tests, I'd love to hear if they're getting easier.
Yeah, so there's a couple of different types of peripheral vision tests. And, typically the one that I showed, it can be quite boring, as Larry might know. And, a big challenge for that test is not necessarily seeing the light, but it's actually paying attention and, staying awake. So there's been a lot of advances in visual fields. One that I'm excited about is, a virtual reality type of visual field, which are people are using. They're still being validated, but I think they will become more and more mainstream. But essentially, you put on these set of VR goggles, and different targets will show in the goggles, and you will be able to, click a button, or there's an eye tracker where it can see if your eye looks at that target. So, I think that's pretty neat. That's pretty exciting. And, it's kind of how the meta or virtual reality is kind of gonna intersect with glaucoma.
We also had a question about sleep patterns. Do they affect the likelihood of getting glaucoma or even cataracts? I don't know.
That's a good question. I don't know that anybody's looked at how sleep patterns affect glaucoma. There is evidence or studies that show that untreated sleep apnea is a risk factor for progression of glaucoma. So, I think that shows that it's really important to, get a sleep study, or if you snore, or be treated and use a CPAP consistently if you have sleep apnea.
And maybe since I have the two of you, you can explain something I have in my own experience. One afternoon, I had a floater. So when I called the ophthalmologist for an appointment, I didn't know what it was. All I saw was this filament, and the receptionist said, "Oh, you have a floater." So immediately, as we all do, I Googled floater and read all this research about I probably had a detached retina or some other retinal problem. And when I went for the eye test, he said, "No, your retina is just fine, and your brain will take care of it. It will stop seeing the filament." Now tell me how that works. Tell me what my brain's going to do.
Should I take that one, Austin?
Yeah, maybe like a neuroadaptation, or I guess, or yeah, that would be your lane.
No, it's a good point. I mean, the floaters, essentially what you're seeing is the jelly, the vitreous inside the eye. The vitreous is basically throughout the eye, and it has a firm attachment to the back of the eye, which is the retina. And in areas that retina and the vitreous are very firmly attached. And if that vitreous pulls off of the eye and it undergoes normal age-related changes, we all go through these as we age, the vitreous goes from being a nice uniform jelly to have little pockets of liquid within it. And those pockets of liquid can collapse on themselves. And so the vitreous can pull off of the retina. And sometimes in those areas where the vitreous is really firmly attached to the retina, it can actually take a piece of the retina with it and create a tear. And if it creates a tear, then the fluid inside the eye can get underneath the tear and lift that retina off like wallpaper, you see? And that's where the floater can sometimes be the first sign that there's a retinal detachment or retinal tear. Usually, when you have that floater and there's retinal damage, usually there will also be some flashes of light where you see these kind of lightning streaks in your peripheral vision. It doesn't have to mean that there's a tear, but a tear is usually accompanied by those little lightning streaks, okay? But when the ophthalmologist goes in there and looks and go, no, your retina's fine, but it's because the vitreous or the jelly came off of the back of the eye, and you see those floaters, you're actually seeing those little floaters casting a shadow on your retina, okay? And why does it kind of go away over time? A couple of reasons. For one, the brain does adapt and it realizes this is not a true image, and it will cancel this thing out because it recognizes it's actually deleterious to normal function, okay? Happens automatically, irrespective of age or so forth. It just kind of happens automatically. Also, over time, that jelly will descend with gravity, and there it comes out of your central vision to some degree. And that's why over time, if it just physically falls down, you're not noticing it as much. But you will notice it when you typically are kind of in a well-lit room, kind of looking up, let's say in the morning when the sun is coming in, you're looking at the white ceiling, you might notice it there because you're getting a lot of peripheral light, and that peripheral light then casts a further shadow and illuminates those little floaters.
Oh, that's great. Thank you so much.
problem.
We have a question here from Lynn Bluberg, who says, I have sudden onset macular degeneration, recently diagnosed. My mother had both macular degeneration and glaucoma. This is genetics. My siblings both have only glaucoma. I am a patient at Gavin, Herbert. What are the chances of me getting glaucoma as well?
Good deal. Good question. So definitely glaucoma is hereditary. One of the biggest risk factors is age as well. And then intraocular pressure, that's another big factor for progression of glaucoma. Having a first degree relative definitely increases your risk. And in a few studies, it showed that one number that's quoted is having a first degree relative increases your chances of developing glaucoma by 15 times. And so, I think that it's just really important that you continue to get eye exams and evaluated by the retina specialist, because they are looking at the full eye. They're not just looking at the retina. They're looking at the nerve. They're looking at the cornea. They're looking at the vitreous as well in the lens. You can ask them, you can say, well, how does my nerve look? And they may say, the rim looks really healthy, and it looks like you have a 0.3 cup to disc ratio. And that's kind of a little measurement that we use to kind of measure and kind of determine whether somebody has a higher risk or a lower risk of developing glaucoma.
Thank you. Here's someone who's had cataract surgery and his vision still isn't that great. He wants to know if there seems to be a film in front of his macula. Should the film be removed?
So that could be, okay, should I mention, take that one? That could be what's called an epiretinal membrane. An epiretinal membrane is basically a proliferation of some cells, a layer of cells on the inner retina. So when you look at the retina, it's got 10 layers, and on the very top of it, there can be a proliferation, and that can be there without having had surgery. It can be there due to inflammations, and it happens more commonly in diabetics. But anytime that you've had surgery, it does increase that risk. And so if your retina surgeon or your general ophthalmologist noted there to be this membrane, then he or she will follow that. They'll try to determine whether this is becoming, more problematic, if it's becoming thicker. And generally speaking, what they'll do is they'll kind of correlate that with your vision and your visual symptoms. So all the time, every time that one has an ERM, it's not necessarily recommended to have surgery. Different specialists, different retinal specialists have different thresholds, but generally speaking, at least in my experience, vision that's better than 20/40, 20/50, most retinal surgeons will not suggest surgery for that. Although there are exceptions when there's a lot of distortion or the membrane looks particularly robust or thick. So it's kind of one of those things that does occur, and that kind of needs some serial follow-up and certain parameters like visual field, visual acuity, and degree of distortion, degree of different sizing of the images. Usually an ERM will cause the image to look a little larger. And if it's significantly disparate, it might be an indication to operate. Yeah.
So curious, if you have cataracts, are you likely to get glaucoma? Are these two totally unrelated things?
That's a good question. No, it's not. It's more likely that you'll have a lower pressure if you have cataract surgery. So one study showed that the pressure in the eye was 17% lower after cataract surgery. So you're actually going to have a lower pressure after cataract surgery.
Okay. And this will be the last question. I mentioned before that as soon as I knew I had a problem, I Googled it and began my own self-diagnosis. Do you find that this is an advantage with patients that come in with ideas about what they have, or is it disadvantageous for you as medical practitioners?
Maybe each of us could take this one. Go ahead, Dustin, and then I'll give you my thoughts.
Well, I think it's great. I think it's really nice when the patient comes in and they kind of are asking questions. They're involved in their care. They've read. They're educated. I think that really gives a different perspective, and they may be right. And I think that if the patient's willing to work together with a team effort, that really makes the care that much better, especially when the patient's reading and being educated and giving us their thoughts.
I agree too. I think that this day and age where people come in with much more information, it almost always is helpful. Very, very few times is it hurtful. I think only when it becomes hurtful is that if there is difficult to adopt a plan. I mean, I think there's much better conversation now between the physician and the patient than maybe in the past. I don't know. In terms of it, there really isn't this patriarchal or matriarchal kind of an approach. I mean, that you just don't take that these days. We learn that there's so much more to be gained by answering specific questions for patients, as well as having context. And I think people are more likely to follow your advice if they understand it better. And if we kind of, as opposed to just telling somebody what to do. And so I don't think that works. So I think that as Austin says, I mean, most of the time, vast majority, it's more helpful to have information. As long as we're able to have a conversation about what are things that kind of maybe are a bit misleading on the internet or out of context, as long as we can have that conversation, then I think more information is better.
Okay, that's great. I guess there's another one that came in here. How is TAD, I'm not sure what this is, TED differentiated from pituitary tumor in a patient with asymmetrical proptosis, OU with pain in only one eye?
This sounds like a typical consult. This sounds like a typical consult for us. Now, so TED is thyroid eye disease. And the question is, how is differentiated from a pituitary tumor? Because one of the hormones the pituitary produces is essentially thyroid stimulating hormone, which essentially is part of that whole thyroid axis. And it's a great question. We do consider pituitary tumors in anybody who has evidence of proptosis or thyroid related changes. Having said that, the vast majority of thyroid eye disease, which is the bulging of the proptosis, the thickening of the tissues surrounding the eyes, the sort of stare-like appearance that takes place, as well as the crossing of the eyes, almost always that's not related to there being too much thyroid hormone, although too much thyroid hormone is hyperthyroidism is a risk. It's an autoimmune phenomenon. And we generally see something else called TSI, which is thyroid stimulating immunoglobulin, which we test for, which is not part of a pituitary tumor. So with the pituitary tumors, you don't get TSI elevation, but with an autoimmune problem, you do get TSI elevation. And TSI is much more consistent with the TED findings that we see on the exam. In addition, the clinical findings are often supported by what we see on a CT scan or MRI scan. The CT scan or MRI scan will show us an abnormal pituitary tumor most of the time. We'll see it there. Thyroid eye disease, we see enlarged muscles and we see the eye coming forward, and there are typical imaging findings or CT or MRI findings of that. So we're able to differentiate TED pretty easily from a pituitary tumor most of the time, because the findings are more inflammatory in thyroid eye disease as opposed to hormonal, like we see a pituitary tumor. But it's a complicated answer to a complicated question, because there's a lot of nuances, but it is readily differentiable.
It certainly points out the importance of the MRI too, doesn't it?
It really does, because you can actually now physically see the tissues that you're looking for, and you can compare them to what you'd expect, either to the other side or to a normal patient and so forth.
So, and this will be the final question. This is looking to the future. Is there any evidence that optic nerve regeneration will be possible in the future? Will we be transplanting pig optical nerves in our eyes like hearts?
Well, we could have started with this one. This will take a whole day to answer. Austin, do you have a thought, and then I can give a thought too?
Yeah, well, I don't think we'll be transplanting pig optic nerve, but there are a lot of scientists and researchers working to regenerate the optic nerve and regenerate the retina. And there have been promising studies that have been published, especially one recently, which showed some promising data, and more in a laboratory, not in human. But I think there's been a lot of baby steps, and that's definitely something that is on the horizon, and I'm definitely looking forward to as well.
Yeah, as Dr. Fox mentioned, the problem with it is, of course, as Kelly writes, stem cell. That of course that's probably going to be the primary way that we can bring cells in when a cell has already died, right? This is about regenerating cells that have already died. And the main issue in optic neuropathies is that this cell, even if you're allowed to regenerate, has to make really exquisite connections with the rest of the brain, right? So that's why we sort of made this idea about the optic nerve heading into the brain. Each one of those million axons, it can't just connect to any old axon. It has to connect to the exact same neuron that's a corresponding neuron in the brain, and the thalamus, which is in the middle of the brain as your main relay station, and then further back. So there's an exquisite mapping that takes place with every single neuron that has to go into the brain. So just keeping it alive is one thing, but then having it reform 1 million connections per side in a specific manner, that's where the challenge becomes massive, not insurmountable, but problematic. And that's why it hasn't quite happened yet. And optic nerve regeneration researchers are working with folks that are looking at how to pull a regenerating nerve into the brain using magnetic fields, electrical fields, and so forth, to pull it in to then make the right connection. So there's going to be kind of a multifaceted approach that gets us to be able to, create life out of something that's already not there.
That's amazing. And it demonstrates once again how totally complex and mysterious the way our human body works, and what a miracle it is for us. So I thank you, Dr. Vivek Patel and Austin Fox, for speaking to us tonight. And I want you to know that this event is recorded. It will be available on the Library Foundation's YouTube channel. Our next event is with Dr. Andy Wang, who will be presenting guidelines on primary prevention of cardiovascular disease. Oh dear, he's going to tell us what to eat and how much to exercise and what not to drink. Okay, thank you so much. Everyone go forward, stay healthy, and be well.
Thank you, Adrian. Thank you.